Hello again, this is Chau, and this is the fourth and last video in the ophthalmology series of clinical primer videos for Case Western. So I'm going to talk a little bit about the basic eye exam. This is geared towards primary care as well as emergency room students. You'll use these skills in those two settings. It's pretty basic. You'll probably use them as well in an ophthalmology office, but it definitely doesn't go into the eye exam in as much depth as you would need to for ophthalmology. Okay, so here we go. Thought I'd start off with alphabet soup. So you'll see all sorts of abbreviations in ophthalmology, and they can be confusing. So OD is oculus dexter, which means right eye. OS is oculus sinister, which is the left eye or evil eye. And OU is both eyes. You might see a T, which stands for tonometry, which is pressure. Sometimes you'll see a symbol that looks like this, a little T with a little, this little arrow-looking thing, and basically you write the pressure of the right eye up here, and then the pressure of the left eye down here. V stands for visual acuity, and the same thing happens. You can see a little shorthand like that, so that you might just see a V with this little arrow kind of thing, and then you'll just see 20/20 and 20/40, and that just means right eye, left eye. You might also see a V with a CC, which means with correction, meaning the person was wearing glasses. Or you might see the V with an SC, which means without correction. Maybe they forgot their glasses that day, and so if their vision is 2200 but they normally need glasses and they weren't wearing them, then you're less worried than if their vision suddenly changed and they're wearing the glasses like they're supposed to. And then you might also see BCVA, which means best corrected visual acuity, meaning after glasses, after we give them a new prescription, this is as good as their visual acuity gets. All right, so hopefully that helps clarify a little bit of the alphabet soup that you might see in an ophthalmology office. All right, so sort of the main initial exam that you can do without any fancy equipment involves taking a look at the external areas of the eye, examining the motility and alignment of the eyes, checking for visual field deficits, just real simple stuff, nothing super specific, checking the pupils, checking the visual acuity, checking the pressure, and then you might be able to do some color testing or stereo testing if you had the right equipment. And I'll go into that a little bit later. So just starting off, external exam, you want to look for things like ptosis or exophthalmos. Somebody might have a laceration. It looks like this individual, you could describe that as a 3 to 4 millimeter laceration on the lateral aspect of the lower lid that violates the lid margin. Looks like there's some ecchymosis of the upper lid as well, and some surrounding edema and ecchymosis of the lower lid. You might say there's some periorbital edema, or if you had, bruising, you could say there's periorbital edema and ecchymosis. Or the things you might find are some, masses. This right here, you can say, looks like there's a 3 centimeter in diameter mass at the lateral lid margin, about 2 millimeters away from the lateral canthus. This in particular is actually a basal cell carcinoma and would need to be resected eventually. All right, so you can also look at motility or alignment. So with both eyes open, you'd instruct the patient to follow your finger or your pen or something using only their eyes. And so you just start at a point about 14 inches in front of the patient's face and just trace an H pattern while observing their eye movements. And what you're looking for is there any nystagmus at the extremes? In which direction is the nystagmus going? Are there any gaze palsies? Do their eyes move in a conjugate manner? Okay. Visual field testing. Well, this was supposed to be a video for you guys of visual field testing. I guess it's not working. But you can see that the patient is sitting here, and you want to be either sitting or standing in front of the patient, roughly at the same eye level. And what you'll have them do is cover one of their eyes, and you will cover the opposite eye. So for example, if you had your patient cover his left eye right here, you would cover your right eye. And then what you do is basically you can sort of start from way up here and trace your finger down and just tell your patient to tell you when they see your finger. And you just sort of start up here and you go down, they say now. And then they do the same thing from the left, from the bottom, from the right. And since you also have your eye covered, you can sort of get a gauge as to whether or not they have the same field of vision as you do. Some people use this technique where they sort of drag from the outside in and sort of see, you know, how narrowed a patient's field of vision can be. The other option is you can sort of hold up one or two fingers in each of 4 quadrants in front of the patient and ask them to tell you how many fingers you're holding up to get a gauge as to whether or not they have full visual fields. So once you complete, with them covering the left eye and you covering your right eye, then you have them switch and have them cover their right eye, and you cover your left eye and repeat the same exercise again. Okay, so pupils, are they equally round? Are they reactive? If they are reactive, is it brisk? Is it sluggish? Is there an afferent pupillary defect? And APDs are a whole other topic unto themselves, which, there's plenty of YouTube videos out there explaining APDs, but you can use the swinging flashlight test to see whether or not they have an APD, and you can definitely tell whether somebody's got photophobia because they will definitely flinch as soon as you shine your pen light into their eye. So, for example, this patient right here has what you call anisocoria, which means basically a difference in the size of the pupils. All right, so visual acuity. So this, just about everybody has one of these little pocket Snellen charts in their white coat pocket. If not, most offices have one of these hanging up on the wall. And you basically make sure that the patient is wearing glasses if they need to wear glasses, and have them test one eye at a time, right eye and then left eye. If for some reason their vision is so bad that they can't even see the biggie at the top, you can try to have them count fingers. So just hold up, 1, 2, or 3 fingers in front of them at 3 feet, maybe at 1 feet, and you can say, for example, this patient is count fingers at 1 foot, meaning everything else is blurry to them. If they can't even count fingers, you can say, are they hand motion? Can they see a hand waving in front of their face? Again, you want to say their hand motion at 3 feet, at 1 feet, at 10 feet, what have you. And then if they can't even see a hand waving around, but they can just perceive light, you just call them light perception only. And then, if they don't see light at all, then you just call them NLP, or no light perception. All right. Another part of the initial exam is to test pressure. A lot of primary care offices don't have this, but I know that most emergency rooms do have a tono pen. Normal intraocular pressure is between 10 to 21 millimeters of mercury, and you test it most easily using one of these nifty little tono pens. There's a little sterile cover that you can put on, and you barely just touch it to the front of the person's cornea after numbing them, and it gives you a pressure readout. All right, other things that you can also test on vision is color plates. The Ishihara plates is probably what most people are familiar with. Colorblind people will not be able to see the numbers inside of these little pictures. Other things you can test really easily is color saturation. So, sensitivity to sort of the brightness of a red color is sometimes the first thing to go whenever you have something wrong with the optic nerve, whether that be like an optic neuritis or something going on. A patient might say, you know what, when I look at that red cap with my left eye, it doesn't seem as bright as when I look at it with the other eye. So that might give you a clue as to, what's going on with that patient. Another thing that most emergency rooms and primary care offices don't have is this is the fly test, or the titmus test, and it tests 3D vision. The only reason I have it here is 3D vision requires that you have vision in both of your eyes. So if a patient comes in complaining of total loss of vision in one eye, hey doc, I can't see anything out of my right eye. It just disappeared this morning and you can't figure out what's going on. And you give them this test and you have them put on those glasses and they can actually see, sort of a 3D picture of the eye if the fly pop out, then that means that they're faking it because you can't have stereo vision with only one eye. So little tips on how to catch fakers. All right, so that's it for the initial exam. On fundus exam, if you have a panoptic in your office or in the hospital, I would recommend using that. It's much easier to get a good view of the fundus even through an undilated pupil. If not, you can use an ophthalmoscope. That definitely just takes a little bit more practice. All right, so here is a picture of a normal fundus. This is a color photograph of the fundus of a right eye. Here you see the optic disc with the nerve, and you have vessels coming out of it. This is sort of the typical course and the typical size of the vessels that you'll see. You'll see that the macula is sort of this darker color right here. It appears flat. There's not any exudates or any strange things in there, and overall, the fundus itself is a nice kind of healthy pinkish orange color without any pale spots, without any hemorrhages or anything like that going on. Pathology that you might see, this is papilledema. You notice that the optic disc margins are kind of fuzzy. They're not nice and crisp, and that's, indicative of increased intracranial pressure. Other things that you might see, here is a fundus photograph of somebody with some hypertensive hemorrhages. So you see sort of blood, on the fundus. You can see, exudates, and these are all sort of pathologic or pathognomonic for hypertensive retinopathy. So these are all things that you might see on fundus exam.